Hi, my name is Rosalind Caldwell, and I will be presenting my Vulnerable Population Focused Prevention Project. Who are the vulnerable in terms of health care? Vulnerable population is defined by Chesney and Anderson as greater than average risk of developing health problems. Children are considered vulnerable because of their age. As an advanced practice nurse, I am obligated to improve the population that I serve by providing evidence-based care. The population that I will be discussing today are pediatric patients ages 12 months to 18 years with a diagnosis of functional constipation. Constipation may be characterized by as functional, anatomic, neurologic, obstructive, endocrine, metabolic, or medicinal. The Constipation Guidelines Committee of North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition defines functional constipation as a delay or difficulty in defecation present for 2 or more weeks with an absence of a pathological condition. Functional constipation may also be described as pebble-like hard stools with 2 or fewer a week. There are many causes of functional constipation: toilet training, painful passage of stool, perianal infection, anxiety. The child can have a change in his or her normal routine or stressful event, such as the divorce of parents, starting preschool, or even vacation. Hyperactivity, distraction, or irritable bowel syndrome are also causes of functional constipation, and a decrease in fluid and dietary fiber intake, as well as food allergies to milk, eggs, egg products, or wheat. Healthy People 2020 describe health disparities as a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. Healthy People have focused on health disparities for the past 2 decades. Goal now is to achieve health equity, eliminate disparities, and improve health for all groups. Children in the United States continue to experience worse health than most industrialized countries. Racial, ethnic disparities also exist. Medical effects of health disparities are a lack of education, lack of health coverage, and poor access to health care. Medications to treat constipation are often over-the-counter medications, so poor families are more difficult to manage because they cannot afford the medications that's needed to treat chronic functional constipation. Societal effects: we have continued health disparities generated by racial, ethnic, and socioeconomic inequality. One major problem is exposure of children to poverty. The United States has the highest proportion of children living in poverty among industrialized countries. Some chronically ill children, such as children with chronic functional constipation, are not benefiting from the same health benefits as others. Health disparities must be addressed on a legislative level for improvement of access to and quality health care for chronically ill children. My clinical question: will a 12-week bowel management program help a child return to independent toileting of normal stool volumes without the need of medications? The intervention is a bowel management program consisting of medications, behavioral changes, and dietary management. I hypothesize that initiating a bowel management program will help children return to independent toileting of normal stool volumes without the need of medications. A bowel management program will include evacuating the colon, using enemas or medications, sustaining complete evacuation, using behavioral and dietary modifications, and then gradually weaning from medications. I expect an outcome of 3 or more bowel movements per week, fewer than 2 episodes of encopresis per month, no complaints of abdominal pain, and no use of medications for at least a month. I have developed an interdisciplinary plan for children with functional constipation using primary, secondary, and tertiary prevention. The Affordable Care Act of 2010 emphasizes prevention as a means to improve health. Primary prevention consists of general health promotion and prevention. Secondary prevention is early detection and immediate treatment of the disease. Tertiary prevention is alleviating disability and restoring function. Primary prevention consists of a visit to the primary care provider. The child will have a complete history and physical and discussion about constipation, also basic recommendations including adequate fluid intake, exercise, toilet regimen with adequate time for defecation, a healthy diet balanced with fruits, vegetables, whole grains, and fiber. Secondary prevention. This is where the bowel management plan is initiated. Disimpaction will be done if impaction is present. Prevention of recurrence of fecal impaction and dietary interventions, as well as education on behavioral modification. I provided a picture here for you of a patient that has a fecal impaction. There is stool throughout the colon and a large stool ball in the rectum. This will be cleared before bowel management is initiated. The goal of disimpaction is stool output. Tertiary prevention must be done by a pediatric surgeon. These are possible surgical interventions such as sigmoid resection, appendicostomy, and cecostomy. These procedures are needed in patients with fecal incontinence after surgical repair of imperfect anus or Hirschsprung disease. Patients that fail bowel management program may also require surgical intervention. Sigmoid resection may be indicated in patients with megasigmoid. The most dilated part of the colon is resected. A sigmoid resection will reduce the laxative requirement and improve the quality of life. Appendicostomy or cecostomy is a procedure that involves connecting the appendix to the abdominal wall and creating a valve mechanism that allows catheterizations of the appendix for daily antegrade enemas. Both of these surgical procedures will alleviate disability and restore effective functioning of the colon. Stakeholders. Stakeholders support and facilitate successful program implementation. The stakeholders should strive to assist the pediatric patient in returning to independent toileting of normal stool volumes without the need for medications. The key stakeholders in the plan are the pediatric patient, parents, primary care provider, nursing staff, pediatric surgery nurse practitioner, and pediatric surgeons. The pediatric patient should be prepared for all procedures in an effort to ease his or her anxiety or fear. The most important people in the world of the pediatric patients are their parents. It is imperative that as few barriers as possible stand between parents and their child in need. Parents must be supported in their roles and adequately prepared. An important aspect of adequate care is paying close attention to the parent's well-being. Parents should serve as an active member of the healthcare team and act as a resource for other team members. A partnership between the pediatric patient and his or her parent should be greatly encouraged. The primary care provider is important for primary prevention as well as promoting health of the pediatric patient. Nursing staff will assist in the bowel management treatment. Pediatric surgery nurse practitioner will initiate the bowel management treatment, and pediatric surgeons will work in collaboration with the pediatric surgery nurse practitioner. Pediatric Surgical Associates is a team that is well aware of the problem that we are having with constipation in our community, and we are willing to do whatever is needed to assist children of Northwest Louisiana overcome this problem. Strategies to address identified challenges. The first step to overcome challenges is assessing and identifying the challenges. There are several challenges identified when dealing with children with functional constipation. Fear, lack of education, diet, and noncompliance are the challenges that I have identified. Fear is a challenge because children are often afraid to have a bowel movement because of the fear that the bowel movement will be painful. Painful defecation results in stool withholding. The solution is softening stools with oral stool softeners and laxatives. Lack of education. Why? Because parents just do not know. Counsel and education in all phases of management is crucial for treatment and the bowel management plan. Diet. Why is this a problem? Because food is purchased and prepared by parents, not patients. Education is the solution for this problem as well. Parents need to know what foods are okay to enjoy and what foods should be avoided. Food journals are very helpful as far as this is concerned, and the advanced practice nurse should review the food journal every visit. Noncompliance. Why? Because people are busy and disorganized. Close follow-up is very important. A great deal of encouragement is needed for these families, and the entire family should be involved in the bowel management process. Measures to evaluate the quality and effectiveness of the plan. 3 or more bowel movements per week is the goal. Also, fewer than 2 episodes of encopresis or bowel leakage per month, no complaints of abdominal pain, and no use of medications for at least 1 month. I have attached the Bristol stool chart here for your review. Type 4 is the ideal type of stool, like sausage or snake-like appearance and soft. Also, I describe it as looking like toothpaste. Technology to advance outcomes. Electronic medical records to share medical records among providers. Automatic appointment reminder systems to remind patients of their scheduled bowel management appointments. And our child life specialist uses an iPad for teaching, and I think this is a great idea. In summary, the advanced practice nurse will assist the pediatric patient with functional constipation to return to independent toileting of normal stool volumes without the need for medications. The goal will be accomplished by establishing a 12-week bowel management program, which will consist of medications, behavioral changes, and dietary management. Thank you so much for watching. Have a great day.